Welcome to Business and Technology in Bermuda. Our goal is to meet with the leaders and thinkers shaping our island's economy to discuss what it really takes to build, scale, and sustain a business in Bermuda today.
Hi.
Hi.
Dr. Kim Watkins. A little technical difficulty. We'll start over again.
Mm-hmm.
You have your PhD in rehabilitation and neurorehabilitation, physical therapy, which you mentioned. You have been all over the world. I was just listing before I realized I need to actually press some buttons. The UK, the US, New Zealand, Argentina, sorry, I missed that one, Italy, and Bermuda. And you were explaining how lucky you were to do physical rehabilitation and neurorehabilitation basically in every free country in the world.
So just before we had started, we were just saying that it was never my sort of thought to go to these places. An opportunity came up and I thought I would give it a try, and I feel like every time I go to a place I learn something new and understand about healthcare, and I just get to meet these amazing people along the way, like not just patients but people that are working in healthcare and people that are around. So I feel very, very fortunate.
Just kind of going back in your education a bit, did you always want to do rehabilitation? Did you start, in the STEM arena, science, mathematics, and biology, and then any of that would guide you, or were you always interested in medicine and then rehabilitation happened naturally?
Yeah, so I feel like in the UK we start quite young. We have to kind of decide what direction we want to go, and I didn't really know. So kind of like you said, did some biology, some science courses, things like that. And when I went to university, I actually wasn't planning to do physiotherapy. I was going to do this nutrition and science course. And then I realised that it was a lot of not interacting necessarily with people. Things have changed now, but the course that I did was very lab-based, so not necessarily interacting with people. And I was like, that's not really going to work for me. So super, super lucky. I actually ended up going to the States. So my mum is from there, and I ended up working one of the summers in one of the hotels there. And I actually ended up meeting a physiotherapist who discussed that it's not just sports injuries and all of the musculoskeletal stuff. There's so many different areas. So she was like, there's cardio and neuro, and like after people have had surgery, and obviously as like a 17, 18-year-old, you're like, oh, that sounds cool. I can meet some people. So I went back to the UK and then ended up coming off that course and then trying to apply for this physiotherapy course that I had got into before, and was just super lucky. I went to the University of Hertfordshire and just had some amazing educators, and I actually from that just wasn't really sure what I was going to do, but you end up doing your rotations and things like that. And then my brother was in the States, and so he was like, why don't you come out here for the summer or a few years, and end up getting a job there and end up working. And so I think all of the places I've been, it's just because people are like, come and hang out and try something, and it's worked out. I'm super lucky that it's worked out. And then I was in basically the States. So my brother's in Hawaii, was there for almost 5 years, and then obviously started to jump around from there. And as I kind of went along, I realized what I liked doing. So in the beginning I was working in an outpatient clinic, so doing more like musculoskeletal pain stuff and women's health, and then kind of realised that it wasn't really, obviously everything's all interconnected, but it wasn't really what I wanted to do. And then ended up going back and doing my rotations when I went to New Zealand, and just fell in love with neuro and rehabilitation, and just realised like the rapport that you can build with people, and just the connections you can make, not just with the patient but also like the family. You're just on this journey with them, and the small wins are just so amazing. Sometimes I felt like when I was in the outpatients, like you would get to have that interaction, but you would maybe help them and then you wouldn't see them again, right? Versus maybe with the neurology, it's like sometimes can be really tough, obviously, because people are going through these life-changing events, and it's really, really can be emotionally draining for them, and it's really hard. But like because you're on this whole journey with them, you're kind of very invested and excited when they win. You feel like you win as well.
Yeah, that's awesome. It's funny. You mentioned dealing with kind of people and patients. I was going through the MCAT for medical school. So it's what the Americans have to go through for application to medical school, and I was suffering through organic chemistry and regular physiology, which all those classes I thought I really enjoyed. Organic chemistry to this day I don't believe is actually real science. I think we were just trying to memorize things in books
to pass the test, right?
Yeah, that was a tough class. And I had a great professor, funny enough, in organic chemistry, who was a forensic scientist for the New York State Police, and he had some great lectures. One of them was about distillation of a cat that was in a house fire and how they use the off gases to find out what chemicals are used for cellulars. Anyways, but one of the crazy things that was happening at the time in kind of the medical world, because I was an EMT, I was going through paramedic school, and then I was taking the MCAT all at the same time, there was a change. I think it happened right after I was doing my MCAT rounds, where I guess whatever governing body was in charge of the medical testing was basically saying, from what I remember, that we have too many doctors who are too analytical and not enough doctors who clinically can relate with patients and build a connection and have some kind of empathy. There's just too many, hardcore scientists at the time in medicine. Was that something you kind of went through? You felt that yourself when you're kind of going through? I mean, these classes are pretty intense. It would probably make some of my orgo classes look pretty hilarious. But there's a lot of science. I loved all the science except for that class. But did you find that when you were in your rotations and when you were studying, like I have some hardcore scientists who are very book-driven versus people who need to connect with patients?
Yeah. So I think that's a great question in regards to, in the UK, you're forced to kind of have that patient interaction when you're first doing even your student placements. So you have the very intense classes, but you have to pass your placements to go through. So if you didn't have some sort of, obviously learn on the job, if you didn't have any sort of interaction with people, some people really did struggle with that. You'd obviously end up redoing some of your classes and things like that. I found when I went to the States, because I had to do the same thing with the exams and stuff for the licensure, I actually, it was really hard because you have to learn how to basically pass the test, right? Because it's so different to any of the other exams that I had ever done. So you can see how you're really focused on what is the textbook answer, but obviously the person in front of you is completely different, right, than maybe what the textbook is saying. So you have what they're thinking, their feelings, their values, all of that kind of, other input, even though you've got the evidence-based and you've got what it's really hard. So you do have the people that did have to learn that on the job, especially when you were younger. That's really, really tough if you're very analytically brained. And lots of people go into research from that side. But I was super lucky. I think that I got the patient side first and then have now, since further in my career, done more of the research-based, which I don't think I would have been very good at in the beginning because I wasn't really sure what direction was good for the research, or I was just trying to build that connection, help my patient that was in front of me. Whereas now, obviously, I am aware that research that you can do can help more than just one person, right? So you can kind of see the bigger picture stuff, like the healthcare system things, but you have to do the research to kind of prove that. So I don't know if that answered your question, but that's kind of what my thoughts were when you were saying that is, yes, you definitely have the people that are very analytically minded. This is going to be good editing for you.
We're going to leave that in.
Yeah, perfect. But then you also have the people that are very emotive, but you have to have a bit of both. I don't know if physiotherapy is a little bit different in regards to you just spend so long with the patient, right? Sometimes when you're with a very medical doctor based, you do get the patient, you see them frequently and they're on you're in your system. But I mean, most of the time as a physio, you're seeing them quite frequently, right?
And for, an hour, probably a session, right? Where, primary care doctor might see you for 10 minutes, once a year or, maybe a few hours in the total year if you're very sick. Other specialties, they'll see you for a few hours in surgery and pre and post follow-up, but that's pretty it. You're right. I think there's a lot of the, in Bermuda, they call them allied health. Maybe it's the same thing in the UK because we steal a lot of verbiage from the British system in Bermuda. But allied health specialties or subspecialties, typically that's nursing, physical therapy. Those are really intense time with patients. It's not as much as it is with the specialties in a physician's group, so to speak, where you're a cardiologist or neurosurgeon. To an example, they probably do spend a bit more time because neurosurgery is pretty complicated. But they definitely, physicians will see a patient for a short amount of time and then go on. When I was a young EMT, it was a lot of time with patients. I mean, because you're on the scene with them for half hour, then it's a half hour to an hour ride in the ambulance. But I never see them again.
Yeah, exactly.
I never see them again, right? Typically, you bring them to the hospital and it's over. Where it must be some level of rewarding to get a patient who is pretty debilitated and then walk them through many months of rehab. When I had a back injury and then I had recently a surgery on my arm, and I was in rehab for my back, I think at least 3 months.
Yeah.
You become like best friends with your rehab specialist. I was there
Yeah.
twice a week. How is that process? I mean, emotionally, it's got to be rewarding, if not also pretty draining. I mean, there's some patients who are just not going to get better. But the ones you can help, that must be pretty awesome.
Yeah, I think I've probably changed a little bit as a practitioner as I've gotten older. So I think, yeah, you definitely invest so much. I got very, very, not entangled, but like so invested in people that I wanted them to progress so much, and amazing when they did, right? And then there's so many different factors that impact people kind of on their rehab journey. And when they didn't, I was like taking it very personally that I hadn't been able to help them. So it was on me that I hadn't been able to do that. And so I think as I've kind of progressed, I've realized that there's so many different factors that do have an impact. I'm probably a little bit harsher. My patients will probably give feedback that I'm probably a little bit harsher now than I was back then, because I'm like, I know that this is going to help you now. And I do obviously think about, my patients and what I'm doing session to session, but I don't necessarily hold as much, even though I'm accountable for what they're doing. I'm not putting everything if they don't necessarily progress or it takes a little bit longer. I'm just with them on the journey together to try and help them. It's us together rather than me thinking that I haven't necessarily helped them in the way that they should. I think I've realized how much it is a relationship to try and work with each other, because also as a massive thing is like my goals are not going to be the same as their goals, right?
Right, yeah.
Something that's super important to them, I'm like, yes, that is what we need to do to drive the rehabilitation, but I'm like, I need to do this to get you there. So you've got to make sure that you're a team, right?
Right.
And also we talked a little bit about like the allied health, right? Again, the goals that they have for me will be different from someone else. So we've all got to be on the same page with what we're driving towards. One of the things I normally have a chat with my patients now is like, okay, you say you want to, whatever, walk a certain distance. How do you want to do that, right? Because you can compensate and we can just get you walking. Or do you want to walk with the most, as close as we can, normal movement as possible? Because that's going to be super frustrating in the beginning to kind of do that. But in the long run, that's going to be better. And some people make the decision, they just want to walk however they want to. And we just, we give the option and then we do the rehab to get there. And some people are like, no, I want to get back to as normal movement as possible. And then obviously it's much harder because you've got to try and stop. So sometimes obviously I'm just going to explain a little bit from the podcast. I know some people have the background, but obviously after you've had a stroke, sometimes one side of the body is affected. So you tend to compensate by the side that's not been affected by the stroke. So you're doing everything with that side, and
that side is fine.
Yeah.
Right.
And then it's like really hard because then you become overactive and that other side doesn't need to work. So to then get the person to train and try and do everything on the affected side is super frustrating, right? And so you have to have that conversation. What do you want and how do we get there? And I think probably that's changed a lot since I first started being a physio, just trying to understand that, how much teamwork it is together and what is the goal and how do we get there, right?
Yeah. I mean, it's funny, in emergency medicine, we're all fairly some side of jaded. You see a lot of trauma, a lot of death and destruction, and we don't get as much of the benefit of seeing people get better, like your side of the fence does, which is very cool, and I am probably slightly jealous as a provider.
Yeah.
But I've always said, maybe because of some of the jadedness that just comes along with being in fire and EMS for so long, that if people took care of themselves, I probably wouldn't see them as patients. 80, 90% of the time, everyone's going to have an accident.
Yeah.
Heart attacks and strokes happen to the most healthy people on the planet, as well as people who don't take care of themselves. But when you're in therapy, there must be some level of, look, here is the things you need to get better. Not everyone wants to do that, and that's tough. Not everyone wants to lose weight. Not everyone wants to work out. They don't want to stop smoking. They don't want to stop doing, drugs. They don't want to take, care of their bodies and eat healthy. And you're there trying to get a patient who, could have a much better outcome, but the basics, I think everyone would always say, the basics of sleeping well and eating well and exercise, to most of the population, that is just not on their radar of things to do. And now they're stuck with you for months, and you're trying to get them there, and that's got to be a bit frustrating for those who you just can't pull them along.
Well, I think it's really interesting. So in general, I mean, you're super motivated, you want to work out, you do like all your sports and things like that. So you have that personality and you also have the drive for the goals. Like, I mean, you're doing the podcast, you're doing all of the stuff you're doing on the side. But ultimately, some people don't necessarily have that goal-driven mentality even before they've had this neurological incident, right? So you're now asking this person that's had this huge incident that's affected them to then now be motivated to do exercise daily, to now not use their affected side. And it's like, how do you, you know, obviously we all have different goals and things like that. It's like, how do you get that person motivated, but also how do you get them to be motivated themselves, right? That's part of my job. And like, obviously as part of a team, like psychology and all the other stuff that we're doing, I always find that a really interesting question. So one of my supervisors when I was in the States was like, when she did her undergrad, they had like one module in psychology. She's like, we need like a half a year, even more on it, right? Like, even though we're not psychologists, it's like we're continuously trying to figure out ways to motivate people. And even though we have that goal, it's like, how do we get someone that maybe wasn't invested in exercise before, or even having this neurological incident is now not invested, to then now be this goal-driven person and set goals and then try and be motivated. It's really tough, right? Because we all have different personalities, we all have different goals, we all have different thoughts. How do we do that? I really do think it's trying to build that rapport. So I'm super lucky, like you said, in the aspect that you have months to get to know people, and also family and things like that, that you can do it. But in general, it can be challenging. A lot of people have the very short-term goal to get home, right? Which is like very,
especially if they're in hospital rehab or right.
Yeah.
Which may be the worst place to get better sometimes. Right.
Exactly. So I think it's very hard is that you have the goal, but then after that, it's like, okay, I have this really large goal that I want to do, and then I have these smaller goals, but then how do I get there? I've got to be motivated. And what I say to some of my clients is like, we're all going to have good and bad days. Like some days we're super motivated even before anything's happened, and some days we just are not. It's
Today's
like
not today.
Yeah. And it's like we have to be consistent in some way. Do you do something, right? I mean, the same thing as us, like when we're trying to do work, some days you can like really do it and you're motivated, and some days you, like you said, is like, I just need to rest. Right. And so it's like, okay, here's this long-term goal that I'm aiming for. I mean, obviously the larger thing that we can talk about is like, you know, when people are doing like sports or whatever, you have a race. That's the goal for the race, but actually there's consistency leading up to the race. But why are you doing it? Is it because you want to complete it, or is it because you eventually want to have this healthy lifestyle, right? Don't know what the answer is, and I think it's very like person-based and how you can try and get them motivated. I find it sometimes really hard in regards to the person's had this huge neurological like incident or whatever, and their whole life has changed, right? Whole life has changed, and maybe it might not get back to the way that it was, and you really want to try and help them to navigate this new life that they're going to have. And it's like a massive loss and grief for a lot of people as well. So they're going through this grieving process, and you're like, now let's go and do your exercises and motivated and do your like activities for the day. And they're still grieving this part of the life that maybe isn't what they thought. I think that's really hard as well, because you want to help the person and you need to still be this professional side of it while being empathetic to try and help them, being like, I know that you're feeling this way, but this is going to help you to kind of have a different version of your life that it could be.
Yeah. I was curious, like, obviously you've gone much farther than I have in medicine. You know, I did my bachelor's and now I'm obviously in technology. I've been my whole life, and now my education path is taking me towards like AI and other things that are of interest to me. But I remember in EMT school, and maybe the same is for like physical therapy or early stage PTs, trainers, as an example. A lot of people who get into physical therapy, as I understand it, usually start as PTs, like gym trainers, you know, as an example, because it's kind of maybe one of the first stepping stones if you like that part of the industry, but part of medicine. But, you know, EMT course is like 6 months. Like, it's like barely touching every topic. And then I hated medicine, funny enough. And I wanted to become a fireman in my home like area where I was living in upstate New York. And to do that, you basically had to be a paramedic. They're only hiring paramedics. So I'm like, okay, fine, I'll go suffer through paramedic school. And like the first few weeks, you realize, oh my God, medicine is this hugely complex mystery of science and practice of trying to figure out how to make people better. And it completely changed my worldview about medicine. And I fell in love with with paramedicine and medicine, you know, in my mid-20s. But looking back on it, and even to today, it is constantly changing, constantly. Like, as an example, that 20 years ago was almost concrete knowledge, but super controversial, and controversial today, is backboards and collars. If you look at the research, we should have got rid of backboards and collars like 30 years ago. Like, patients who are backboard and collared, they have worse outcomes. They end up going into adverse conditions like cardiac arrest or difficulty breathing more often. They end up causing more damage to the spine because they're trying to get comfortable on a rigid structure. But there are practitioners, there's ambulance companies, hospitals who are using backboard and collars today. When 95 to 99% of the time you don't need it. You should not use it. Is it the same on the PT side, on physical therapy? Is it like, 30 years ago we knew this, but still today I can't get practitioners to change their school of thought? What's happening in your side of the industry?
Yeah, I think that's really interesting because things do evolve all the time. Like, I feel like I've been really lucky in regards to like being involved in the research that you're able to implement it. I think the hard thing is when you're in part of a healthcare system is that you can do something individually with your like clients or patients, but it's hard necessarily to get everyone else on board. I remember when I was in the UK, I had a supervisor that was doing nothing unsafe, but it just wasn't the best thing for the patient. And so we had this huge debate, and obviously as a student you come across ridiculous, but just being like, okay, well, what's the evidence saying about this? Because this isn't what we should be doing. But it doesn't matter because it's like a hierarchy, right? And it's the same thing right now, right? It's like you're not maybe the most senior person. So even if you were to bring it up, people are going to do what they want to do as long as it's not unsafe. Sometimes it's easier to stick with the status.
Yeah, you're doing it already.
Yeah, the status quo stuff, right? Because it's like they haven't had anything adverse happen to the patient, but it's not necessarily, we know that it's better for this. And this is like really strict evidence. And sometimes it's hard, right? Because you don't have the equipment, you don't have
the training,
access, the training, right? You don't have the confidence, right?
One of the big ones I remember, I had some really progressive physicians. I was at a teaching hospital for my rotations. I think I did like 2 years of rotations, more than I needed by a mile, but I just loved it. And I had a day job in IT, so I could kind of afford to be a student for a very long time. And one of the, and I don't know if it relates to some of the stuff you end up seeing and doing, but one of the very inventive things back, a long time ago was intubated patients who were face down on these very complex and super expensive stretchers, but you would basically be breathing upside down when you were unconscious, when you were sedated, or you were unconscious because of your condition, and the recovery rates were just going through the roof. But trying to get a hospital to buy these beds that you could be upside down basically on your stomach and breathe almost suspended was very hard. And the other one too, especially in the ICU care, a big one that the ICU docs that I was working with at the time were really trying to push was not waking the patient up at night. Like 10 o'clock lights out, and then we might come round, and they were also trying to get the rounding later in the day so patients could try to get somewhere around 8 to 10 hours of sleep.
Because they're literally going through everything in the hospital, right? And then they're disrupting the sleeps, their office pattern, and then they're trying to do their rehab or whatever treatments in the day, and they're exhausted, right?
Yeah, and the nursing have to do, especially in the ICU, they have probably 2 patients. They have to take vitals all the time. There's a million things going on in the ICU. There's beeping, there's crash cars, there's people dying. It's a total mess. And then at 6 o'clock, especially in a teaching hospital, residents come on, and they have to round. And they have to round in order to be doctors. Like, that's just part of the process, right? It's seemingly, as I go through the ICU and ERs today, especially in Bermuda, it's like I'm watching the entire story just unfold again. Like the same conversations we had 20 years ago, we're having right now. We should leave patients alone, let them sleep. Nutrition in the hospitals is pretty much atrocious. People don't necessarily get really better, at least is in my opinion, and please correct me. But the best place for people to get better is probably not in the hospital. Get them out as fast as possible. Get them home or get them into a rehab clinic. How is that progressing now?
So I think that's the thing is a lot of the research now is that, like, obviously once the person's medically stable, trying to get them in the home environment is going to be way more beneficial, right? Because they're going to be able to do their rehab. They're going to be in their environment. They normally have like some support system in place, right? it's a very artificial environment being in the hospital, right? In regards to like trying to get people on board, just to go back to your question, is like, you know, the equipment was super effective, right? But it was probably super expensive. So you had to be like, okay, for this board, when they were like lying face down, it's like, how can we prove it? Until you had the research, you couldn't be like, we're going to invest however many thousands into it. But now probably it's super easy to do because there's so much research to actually come back and be like, okay, this is what works. There was a time when they weren't sure, you know, after someone had an incident of stroke, like, do we get them out of the bed straight away? Now we know that the sooner we can get people moving and up and out of the bed, like the better it is for the outcome. So unfortunately, it's like I said, you are a little bit delayed until we get the research backing it to be like, this is the standard and this is what we need to do for guidelines. I feel very lucky that a lot of the guidelines are already in place. We already know what works for neurological conditions like stroke, right, from what the UK's done, what Canada's done, New Zealand, US, whatever. So a lot of things we know we can be doing from based on that. I know that we're obviously on a small island and everything's like, there's obviously different factors for different places you're at, but like some of the large scale like studies, we know what works has already been done. So it's like, we know these outcomes are going to be better if we do this, right? I think it's always hard when you're looking at cost effectiveness, right? Because a lot of the time you're like, as a healthcare system, you have to figure out how effective it will be with the equipment that you're doing. And obviously everyone's really strict with their funding because everyone's challenged with that. So it's like, I think the more I move up, like in different positions, is like how to balance that, the equipment that the people need, and also, you know, what the patient or person needs. So I think it's always like a never-ending question. Healthcare probably is, if you've noticed as well, is like, how can we balance all of these things? Because obviously if we don't have any funding, we can't see people, right? So it's like, how do you kind of like weigh those options up?
So as you're coming up through your career, you get your bachelor's, then your master's. And at some point you said, I'm getting my doctorate, my PhD. Was that in the middle of your master's? Were you already on the educational track, or did you stop at some point and say, oh, I'm happy with my master's? And now, you know, as you are, you know, theoretically, other than a physician, the most senior person in the rehabilitation field, where do you find your career now? Are you teaching a lot more? You still seem pretty heavy in patient care.
So basically, I was doing my master's. Oh my gosh, my editing is going to be, it's been a long day. Sorry guys. So I did my master's in New Zealand. So I was working basically as a senior rehab over there, rehabilitation specialist. And so basically, when I was doing the master's, it was very much like patient-centered care. And my research project was basically interviewing stroke specialists around the globe and what we're delivering in rehabilitation, what's working and what are the barriers. So the World Health Organization is basically had their mandate by 2030 is supposed to be rehabilitation for all. So it was like basically asking these rehab professionals, what are we doing? And I kind of realized from a global perspective, it's so different, but very similar in some aspects. So then after that, I was like, okay, well, what am I doing? I was actually in Italy. Pandemic happened, and then was going to come out to Bermuda, everyone's story, for a year, and then I'm still here 5 years later. I was like, okay, got here, realized what we were doing for stroke rehabilitation, and I was like, we're very lucky in some aspects, but a lot of the data we didn't have, right? We had like the statistics about incidence of stroke and like some demographic stuff, but we were like working hard. But my doctorate, obviously we still had to do some like professional credits and things like that, but the research project was basically trying to figure out what we're delivering for stroke rehabilitation here in Bermuda. So not just the hospital, all the way into the community. So it was not just one particular area of the pathway. And it was really hard because we don't really have a pathway. People who have the incidence of stroke, they get amazing care in the hospital in regards to like acute care, but then they might have to go overseas because we don't have the rehabilitation here. And they come back and somewhere in the system they get lost, right? So sometimes they get back into the hospital and can get rehab, and then sometimes they don't. It's definitely improved so much since I've been here, but we didn't have any data. So in regards to the question in teaching and things like that, it was very research focused. And even now, still we're doing the survey again to kind of figure out if things are improved, and the hospital is doing a lot of work for their accreditation. But it's been very much based on what we're doing for research. more so involved in more like international projects for research. Like we did a systematic review on what's being delivered and if there's any inequity in rehabilitation, because a lot of the time when people are recruited for research, it's because obviously people want to show good outcomes.
Sure.
So they might be like less severe stroke.
You're selecting your end group.
Yeah. It's definitely so much better. But basically, we did a systematic review of like.
It's not as bad as p-hacking, but it's
it's
close.
So basically, we just wanted to show what we're doing, right? So we did a systematic review, and people were reporting what they, whether the age, demographic information, but there was still definitely an imbalance of people that were getting access. So we did it mostly around digital rehab, things like virtual reality, robotics, things like that. So we kind of showed any of the systematic reviews that were done in the last 10 years, and then how we were actually delivering that care. So I think it's always hard, is there's always going to be people that receive the rehabilitation or the input on these things, like there's, because they can access it, and then there's always people that miss out. So how can we figure out to kind of bridge the gap, I guess? So in regards to that, so more doing like research based, but still like doing a lot in my day job, very patient centered, patient heavy. So I'm doing my day-to-day rehab, but outside of work, doing like all researchy stuff.
You're still researching now after your doctorate. Oh, that's awesome.
Yeah.
It is tough. There is no perfect system. I had a nurse and her partner on a few weeks ago, and it's very challenging with every system. I mean, you read all the news reports out of the UK about the NHS. Mm-hmm. My wife's Canadian, so I hear a lot about the Canadian healthcare system from her family. I grew up in America, so I can tell you, I can tell you all the problems in the American healthcare system. Obviously, for those who have money, your outcomes, I'm assuming, and maybe your research had shown this, is that their outcomes are better because they have access to better doctors, they have access to better rehab, they have access to better healthcare. Maybe they take better care of themselves, or they can afford the medications that kind of counteract the problems that they're developing through lifestyle. But rationing of care, because really that's just what it is. There's only so much money to go around in healthcare systems. You can't spread it out evenly. It's just impossible. It's very tough, and it's not a problem I think anybody really wants to get up in the morning and go, I can't wait to get in the middle of this fight, because how do I, in Bermuda especially, I think I just did numbers on this for another project. It's about 25% of the population, and I'm happy to be corrected, who are under or uninsured, right? Yeah. That is a huge number of people who basically can only rely, because our tax dollars in Bermuda pay for it, only King Edward for their health care, and a handful of doctors and maybe specialists who would take local government pay, right, without a copay or whatever, and that's extremely tough for the really sick. So I'm sure it's a challenge when they come into your clinic or you have them be like, okay, I have you for this limited amount of time, even though it's longer than some specialties will get a patient, but even when they're done, that their ability to continue with healthcare services beyond that is super limited.
Huge point there. So thank you for bringing it up. That is a real challenge for me, and I really struggle with it. After being in different healthcare systems, as much as NHS has its issues, I mean, all systems do. I really struggle when people come in and they can't afford to come for more rehabilitation, just because the copayment is huge, or they don't have as many sessions. It's very different, like obviously having like a knee and ankle injury, right, and the sessions of physiotherapy for what we're talking about, right? It's longer term. And obviously, like we're talking about being in the fight, that kind of thing, it's like, how do we do it? I mean, I know there's lots of changes that we're trying to do, more universal healthcare type thing for people that are underinsured or no insurance, but at the moment I really struggle. If it was possible, I would do obviously like tons of pro bono and all that kind of stuff, but it's just one of those things that needs to sort of change. There's some like really good models for like different charities and things that where people are able to do it, where there's more like an equal access fund. I think that's probably the way things are moving in the short term until things do change, where more things are covered for rehabilitation. I think with like obviously UK, Canada, and that kind of stuff, even US, right? If the person has shown that they're making progress, then they can continue with their rehabilitation to a certain extent, right? In the US, obviously, it's really challenging because people still have to pay co-payments and they have to make a decision between rehabilitation and other things, right? So it's very similar. I don't know what the answer is, and that's something that we're trying to do. So the research was trying to show, like, you know, how do we, what are we delivering? And a huge thing that came up in the survey was people like, I wish I could do more rehab.
Sure. They got stopped before they were better or before they could make more advances. Yeah, totally.
And like I said, it's like people have to make the decision. Do they pay for the medication? Do they pay for rehab? They also have to go and maybe see the specialist, and that's like a co-payment each time, right? I mean, obviously, I myself think that like healthcare is a universal right? That we should be able to do it and be able to be healthy and be able to access the things that we need to do. But I understand that it's the balancing act of how do we allocate different funds for different things and how do we kind of cover that. And maybe it's to be able to do like a charity type thing to cover people that are not able to have that care or don't have any income, or like I said, are not insured or underinsured. Maybe that's the way to kind of bridge the gap in the short term, but obviously things need to change. And obviously with an aging demographic, not just in Bermuda, globally, things are going to change where people are going to need more healthcare services and there's going to be more demand for that. And we also want the population to be healthy, right? And to be back in the community and back in society. And if you don't have the ability to go to rehabilitation, then that's not going to happen either, right? So
it's challenging.
Yeah, it's very challenging. I don't know what the answer is, but I think it's one of those things is having those conversations, trying to bring people to the table, like the different partners is a huge thing, right? How can we do it? How can we get the funding? And also show the outcomes, right? That people are getting back into the community and making progress. Maybe that's the way to do it, but it's hard to kind of show because everyone's so different. So you can't be like, okay, these 6 sessions are all we need for this person until you start seeing them. Okay, well, maybe, so it's something that needs to get delivered, but I think kind of having a supplementary sort of system where we can do that. And like I said, to some people, like going to King Edward, it's amazing that we have the access to that they can do it, but obviously that's going to be limited as well, like, you know, with people having to then continue with their rehabilitation. I think as well, because people have to make the decision, right? And most of the time, if they don't have any access and cannot go to private, it's very hard because your choice is already made for you, right? You don't have the choice, really.
It's interesting. Obviously, there's other countries who are probably in a demographic like or worse than Bermuda. You know, I trust the news sources, and I again happy to be wrong, but Japan seems to be on a very bad track in terms of elderly population, not enough young people coming up through it. And I think one of the things that, if you read the news stories that they're trying to tackle elderly care with and rehabilitation and medical advances is robotics, as an example. For patients who are trying to go through rehab and trying to get better and, whether they have enough insurance or they don't have enough insurance, how is the digital things out there nowadays? Like, is it, I'm a nerd. I go on YouTube. I watch a bunch of stuff for rehab when I hurt myself, right? I go see, friends of ours who are mutual friends. I go see my orthopedist. I see sports medicine. And then I'm on YouTube, trying to find.
And Dr. Google.
Yes, and Dr. Google. And try to find, or AI nowadays, try to find the best solution out there. Is that there's always fraught with danger of people going on the wrong track, but for people who have limited access or who want to go that extra mile, how are you finding the tools out there now digitally or robotics or those kind of things?
Yep, I'm just going to go back to a tiny point just from before. Obviously, research and stuff is changing, but there was interesting, obviously, where we saw the documentary about like the people that were over 100, and they were saying Japan, even though obviously the elderly population, they were healthy in regards to like diet and being physically active into their later years, right? So like walking a lot, like doing lots of activities. They had the support from like family, things like that. So I think it's just trying to get into the mentality as well of like, how can we do like more rehabilitation, maybe like falls prevention, balance stuff, like more things where people feel stronger as they get older and more confident, so that you don't get to the point where it's like this huge drastic drop off. People are kind of more doing like prevention stuff before we get to that point. I think in regards to that, we tend to deal with stuff once there's a problem rather than like trying to tackle it before. So in regards to healthcare systems, if we are able to do that, where we actually, you know, did falls classes or did rehabilitation where people could drop in and do it, or gym access for elderly where they felt confident where they could have a supervised session or whatever, or classes, which I know we do have some stuff here in Bermuda, but making it accessible as well. That's kind of the way to kind of manage it. So before there's a problem, and then obviously as people get older, they feel more confident and less issues as they get up. In regards to the digital things, I think there's a way to kind of bridge a gap. So a lot of people use telehealth, right, to kind of do that for people that can't necessarily access or come in. And there's lots of stuff online, like for the different societies, you know, like Parkinson's Society in the UK and MS and things like that. They do have like programs that you can follow online. Obviously in person you can make it more individualized, but at least there's some stuff out there. I think the issue is maybe with looking up stuff on Mr. YouTube and Dr. Google is that it's not individualized for you. So even if you've got an assessment with a clinician first and they were like, okay, yes, this is great, go ahead and do this. I think there's amazing advances for like robotics and virtual reality and things that are happening in the UK. Again, it's just like whether you can get on the trial or whether it's used as an adjunct to what you're doing for the regular physio OT, things like that. Definitely, I think any questions you have is going to someone who is specialized. I think a lot of people, like even me, I'm like, whatever works, right? Like you can do multiple things at the same time. It's not an issue as long as it's not like counteracting it. You just don't want to do anything that's necessarily unsafe specifically for you. So if you're like, okay, what are you talking about, the robotics or even doing like the digital rehab in another way, like great, do that if it's going to help you, right? And no one person in healthcare can do everything, right? I always get asked about acupuncture, massage, like other things that are there. I'm like, yeah, if it works for you and you're, you know, like healthcare wise and your health, you can do it. Yeah, why not try it, right? Like that's the thing. If there's no reason why you medically cannot do it and you want to try it, like give it a shot. And I think in regards to the way the world's kind of changing, I mean, Europe as well, like there's lots of stuff that are doing robotics, like with people, you know, spinal cord injuries and things like that, right? Because we know that there's going to be issue, but it's like, great, if that gets a person function back, like that's awesome, stuff that we could never have done before, right? So I think that there's definitely amazing stuff on the horizon. But I think it's just kind of working with what we have, but also individualizing it to yourself. Yeah.
Yeah. I mean, it's tough. A lot of my friends, my mom was one of the biggest proponents of some of like the non-traditional medicines, you know, acupuncture, massage therapy. But obviously the evidence, you know, this is me speaking personally, the evidence just doesn't bear itself out. But at the same time, many of those things are not harmful. And if people are doing, you know, the clinical things and
still doing the strengthening, still doing like the posture, still doing everything that they need to do, right?
And you want to see a massage therapist, then fine. It's not a big deal.
So I think that's the thing is like making sure that you're still doing what you need to do. Like say, for example, your shoulder surgery, you still need to do all the strengthening. You still need to do everything to get yourself back. But you know what I mean? If in regards to the pain-wise, it was going to help you, like go ahead. Like I said, as long as it's not detrimental to the person and they try it, and some people try it and be like, it's not working, right? Cool, that's awesome. I think it's just when someone's like, you can only do physio, I'm like, that's not how it works either, right?
as saying somebody who actively plays contact sports and rugby in their 40s, you know, I'm doing enough bad things as well, right? Definitely not in my favor. I know you do a lot of neuro rehab. Love to talk about stroke. On the air ambulance side, it's obviously a big conversation because many of our sickest patients are stroke victims. Let's, you know, for the people who don't know, let's just walk through strokes from the basics, right? And please correct me where I'm wrong because I don't have your level of education. But most strokes are either hemorrhagic or thrombolytic. It's a bleed or it's a clot. Here locally, I think we have a bit of a trouble with both. We can image through an MRI and try to figure out if you have a one or the other. But then typically, at least in Bermuda, and you know this is why a lot of people have to go overseas, is we can only give drugs like TPA to try to break up a clot, you know, a thrombolytic stroke. But also early recognition is huge. I know of this in my training, and it's obviously in all the literature that I'm accustomed to reading. And where are we today with not only the early signs of stroke identification and getting people into the hospital quickly, but how does that all unfold on your side of the fence? You know, someone comes in with a stroke, and probably by the time you see them, it's days or weeks beyond that stroke. How is rehab on that side nowadays?
I think actually as a community, there have been lots of campaigns. The Be Fast, you've probably seen it all around the hospital. We did a lot of campaigns about like trying to get people to understand what the signs are. I think it's really hard because like even though we have that, I mean, we just say, like for people that don't know, so Be Fast, obviously balance. So if people are very quickly unbalanced, any issues with that, or you see them veering. Eyes, any issues with vision, one side blurred, or just, you know, both parts of your vision. Face, if you see their face is drooping, like that's one of the signs that people will be aware of now. Arm, if they're not able to raise their arm, but basically they've changed it to arm or leg. So if you notice there's a very, very quick change in weakness on the arm or leg. So speech, so any slurred speech. So things like you get them to repeat a sentence in the sky blue, and then they'll be like having issues with that. So time. So the main thing they've been trying to plug so much is time. So we're trying to get the people there as quick as possible, because we know the quicker we can get people there, the less damage there is to the brain, right? I think probably since I've been here over the time, that's been a huge, huge thing that's improved. I think they've done a really good job with the acute stuff in the hospital.
I know John Hopkins was here and helping the hospital push to get the stroke identification numbers down and get drugs on board quicker. And,
yeah. And triaging, super good with triaging to get people through. So I think when I first got here, it was really hard. People coming to see me maybe years out after their stroke, and they maybe hadn't had rehabilitation. Obviously, we talked about before, it's really hard because you've already got these compensations. You've got secondary issues, things like we talked about spasticity and tightness in the affected side, or pain, and things that are really going to make an impact on top of already the damage that's happened to the brain. I think people are coming into rehab quicker, maybe in the outpatient community, but there is still a little bit of a obviously it depends on the person, right, how severe the stroke is, but there is still a little bit of a delay for people, right, coming through. But I would say in general, people are aware, like now once they go to the hospital and things like that, like that they know the rehabilitation has to happen as quick as they possibly can. So I think that's a huge improvement. Obviously when people go overseas, a lot of the time they have access to more intensity for the rehabilitation. So whether they go to US, if they get air ambulanced out, or UK, they will get this full service of speech, OT, physio, psychology in the hospital, very intense rehabilitation. Obviously, it'd be great if we could have that here all in one place, like that specialist clinic. Obviously, we have the hospital and we have the outpatient service, but if you're trying to obviously deliver that service for everyone, it's not just for stroke rehabilitation, it's really hard, right, to keep that intensity up, especially for staffing and things like that. So the ideal would be if we could have a clinic here in Bermuda that was specialised, being able to deliver the things that we do overseas in the US, but doing it here would be great, right? Because the person's not out of their regular setting. Even if they're coming in for rehabilitation here in Bermuda, they like are still around their family. They still have the support system. They still are able to do things in between in their own thing. They're not obviously having to think about travel, and they can also practice things at home, right? And then still come in for the rehab. That would be an awesome way that we could do that, is to have this specialist clinic here that kind of delivers all the services at the intensity that they're delivering overseas.
Yeah, that makes a ton of sense. And a lot of things that we, on the air ambulance side have been a proponent of is the faster we get people to definitive care, where, if it's a clot, obviously TPA as an example can do a pretty good job of helping relieve the symptoms. But if it's a bleed and they need a helicoil, no one's floating those in Bermuda, right? So the faster we can get the brain reperfused, the faster that patient's going to have a better outcome. Is it the same when you're dealing with other kinds of rehab, spine, spinal obviously being somewhat related to neuro, traumatic accidents? People in Bermuda, obviously, we don't have a great record when it comes to traffic accidents and bike accidents especially. Are you seeing the time, obviously it's not maybe as critical in terms of rehab post-injury as a stroke, but certainly it's a factor. I break my femur. I need to come in for rehab. I'm assuming, I think you hinted to it with a study you mentioned before, but the faster you get even those patients for musculoskeletal, the better their outcomes are as well.
Yeah, 100%. So if someone has like a brain injury, obviously as soon you can get in, so less secondary complications, hopefully, get them back to kind of the way they're moving, and also just get them back to like better functions. The more we can do quicker rehab, you use spinal cord injury, brain injury as like one of the examples there. But yeah, it's really important if we can try and do the rehab as quickly as possible. So obviously we're still trying to make the connections, right? So with the brain injury, you're still trying to make the connections from the brain to the body. So the sooner you can kind of start that process, the better with the intensity. And I think there is still a little bit of a gap. And I think some people are super lucky, obviously have support systems in place and things like that. Some places, this is generic comment before, I don't want to get you in trouble, but some places just in the community it's a little bit harder for like wheelchair users and trying to get back into it, right?
There's plenty of places in Bermuda who aren't wheelchair accessible.
Yeah, so it's really hard, right? Obviously, a lot of time people want to like be able to do it, so you've got to get the person better with the rehab to be able to like at least sit in the wheelchair or to be able to like go out and things like that. Obviously, and if they're in their house and doing things like that, you want to try and get them up and moving if they want to get back into the community. So I think getting access to rehabilitation as quickly as possible is, for a lot of many conditions, is the key, right? And also to be able to keep that intensity of rehabilitation.
Right.
Because obviously if you're seeing someone once every 3 weeks and they need it once a week, then they're going to be starting again from where you are, right? And so I think that's kind of what we need to address is like for more of the longer neurological conditions, like, I mean, I have patients that have had like Parkinson's disease, right? And so like keeping that intensity is sometimes harder because they come in and then you're kind of like starting again with all the cueing and things that you were like doing before, versus if you're seeing them weekly, it would just be adding on to what you're doing, right?
Yeah, I have found it, you mentioned Parkinson's, Lou Gehrig's disease as another one. I have found it's been pretty amazing to be in the very periphery of some of these diseases and just see them online or read about them in a journal. It has been pretty impressive, if not miraculous to some extent. As an example, in the 60s, 70s, 80s, AIDS was a death sentence. Mm-hmm. And now with the antivirals that they have out, sports celebrities like Magic Johnson is expected to live to his 90s with HIV and AIDS. Whereas you've seen people like Michael J. Fox, to see people who are famous who are living with these really bad, debilitative, neurological degenerative diseases, who are really high functioning, if not fairly normal. Are you seeing some of those patients in Bermuda? And obviously you get to see maybe some of the cutting edge stuff that's coming out of research centers. Is that part of the research that you're working on now, or?
So at the moment we were talking a little bit off air just about different courses and things. So I'm doing a specialist course for Parkinson's disease. There's lots of research they've done from the UK about different sort of protocols. But a lot of the stuff is really based about intensity and trying to keep the rehabilitation up. I think obviously you used Michael J. Fox as an example. Like some of the stuff he's done for research and the funding and things for Parkinson's disease is going to continue to drive it forwards.
Some of the diseases are just not super popular, so people don't see them.
And this is impacting, them or their family member, right? I know lots of stuff in Canada was being done with MS, right? Where they were trying to figure out some of the processes to see if they could make a difference with that, and then the rehab alongside it. So I think alongside what everyone else is doing globally, eventually like Bermuda will be able to catch up with what we're doing. But I think it's just the main thing is the intensity of the rehab being covered by the insurance so people can continue to do it. Because a lot of the time people really do have the drive because they want to get better or they want to do it. It's just you kind of want to have the supervision of someone helping you to go through it, right? Because if you're already scared of falling, say for example, if you had Parkinson's disease, and then you like go and do these exercises on your own, like it's going to be really hard for someone to do that with the confidence versus if they're coming into the clinic to do that and then they become confident to do it on their own. So there's definitely people that are making progress here and super motivated to do that. I think at the moment with a lot of the neurological conditions, like there's like a driving force behind stroke and stroke rehabilitation. We talked about that some of the people who've managed to do the charity for it, right? They're driving forwards for education and trying to do support groups and things like that. MS Society, they've got people that are trying to do that. They're working with some of the doctors over in the US, here in Bermuda, doing amazing work. Dementia Bermuda is doing amazing things as a charity. So a lot of the things are kind of like somewhat separated, but kind of bringing everyone together is the way to do it, but kind of using what we're doing globally and how we can implement it here in Bermuda.
I mean, a reoccurring theme I'm hearing from you, number one, is intensity of rehab, maintaining a high tempo, if I were to use maybe a military term, of keeping people engaged in rehab so that they do get better. I'm assuming you've seen that in the research and of course, trying to find the funding and trying to get charity involvement to fill where government insurance or government care or private insurance stops, right? Because there are hard limits on all of those. And getting charities to help as a third sector, as I call it, fill in the gaps. Are you seeing, research that shows it being beneficial economically? I'm assuming the more I do rehab and the faster I get better, my logical assumption would be I get back to work faster. I rely less on other services. I don't need a wheelchair or crutches as long. I'm not needing home health care as much. The nurses don't have to see me. I'm assuming there's knock-on benefits to this. Is that part of the research you're seeing, or
100%.
should we just be acknowledging this is just reality and move on?
No. 100%. That's the thing, right? So we always think about rehab being like the physical improvements, but like I said, if the person's dependent on their carer, right? The carer maybe is a family member now that like can't work, right? The family member can maybe go back to work. They can return to work. They can return to community, going out socially, like doing events, giving back. Some people want to do volunteering, right? So some people have the goal to volunteer. So as a society and a community, like doing the rehabilitation will have those knock-on effects. I think it's always hard with some of the research. Like, how can you put a number on it, right? That you've saved these many days. Obviously, from the acute side, you're like, I've saved these many days for bed stay in the hospital, right? And once you get to the community, like, how much money have you potentially saved is very difficult, because, like, is it the care that you've saved? Is it, like, the person returning to work? Is it many other aspects? So I think it's like we talked about in the beginning, is setting those goals that are meaningful for the person as the first thing, and then kind of being able to figure out what the knock-on effects could be, right? Because if someone's reaching those goals, then they're going to be more likely to have an impact and return to their life they want to in the community.
How is I just am curious about another part of your aspect, because we don't deal with it so much on the emergency side. You have to interface with so many other specialties, and I think I would agree that I had very little training when it comes to psychology. What are the other specialties that you're dealing with, and how do they kind of influence the rehab, the whole picture of rehabilitation?
So occupational therapy, speech and language therapy, psychology, and then from the other aspects, you've obviously got dietitian, we've got orthotics, so people if they need braces and splints and things like that. Obviously rehabilitation, nursing, and seeing a physician, like neurologist, things like that. So working together as a team definitely is important, right? Because if the person's goal, say for example, they're impacted with their speech, the person's goal is they want to get back to, say for example, they want to like deliver a speech, or I had a patient, for example, that wanted to deliver a sermon, right? And for me, the goal is like, okay, you need to walk up there, right? You have to do the stairs, whatever. They're like, nah, I just want to work on my speech. That's the most important thing, right? So it's like, you've got to do it in regards to like the whole picture, right?
It's a good psychological trick to say the thing you want to do needs to involve the thing you kind of don't want to do, right? Yeah.
100%. So there's definitely ways to get around it. But I think luckily in the community now, we've managed to build a little bit of networks between the healthcare providers. But a lot of the time, it's slowly changing, but a lot of the time you have to go back to your GP to get a referral for another profession, right? Now we can sort of email each other and do referrals, and people can self-refer and things, so it's definitely changing. But a lot of the time you have to have the healthcare professional be like, okay, I think you need speech, or you need OT, or let's get you back in the hospital, and have all of the professions together.
It is a bit, on one hand, I can see it to have, and it must be kind of insurance driven to an extent, where the insurance company's like, well, we want a medical professional to see if you need speech therapy. You're like, I had a stroke. It's a pretty big one.
Yeah.
I'm not speaking all that well. I have left-sided weakness, which affects my jaw, my tongue, you know, everything I need orally to speak well. It's obvious, right? But at the same time, they're like, oh, please go see your primary care doctor so we can write you a script to go see speech therapy. So some of it does seem a bit like a paperwork exercise to some extent. But it is, and I'm sure to me it seems pretty natural to need all these specialties to work together to try to get a patient who's really debilitated post-stroke, post, you know, a serious accident, you know, better. It is quite interesting in how those specialties would work together.
And I think one of the things is like some of the other countries I've worked in, they had like a, for lack of a better word, coordinator, caseworker, like a nurse specialist that would be basically following the patient through what they need, right? Because a lot of the time patients don't necessarily, or people don't necessarily know what they need until someone tells them that that's the option or what they could be doing. And I think it's really hard that you're maybe have the incident and then you have to navigate that on your own. We don't really have that system as much here yet. And that's something that would be awesome for a lot of conditions, right? To have the thing. I know that some of the insurance companies are now having like a caseworker role that's coming through, but if you don't have that insurance company, it's very hard.
You might not get it.
Yeah.
It is easy to slag on the insurance companies sometimes, but I have seen, especially here in Bermuda, maybe because I'm just seeing it more often, that there are programs they're kind of come out with. You get, you know, rebates, you get physical therapy sessions, they put wellness clinics on. There does seem to be a shift in the financial side of medicine and in the medical side of medicine, you know, medicine that, and as you said before, prevention, you know, I've heard this my entire life, is really the key to not being in front of someone like you or me with some kind of debilitating injury or illness. But it is good to see these programs starting to incubate inside like the insurance companies as an
100%.
example. Is there ones that you found that have kind of started to move the needle a bit?
Yeah, I think some of the private insurance companies, like, I mean, I don't know what your system is. I know some podcasts you can't say names, right?
Okay.
But I mean,
Fine with me.
Yeah, no. So All Shores have done it awesome with like some of their wellness. They've now got a wellness coordinator that's running some of the programs, which is awesome. Yeah, and I know like CG is trying to do some of this stuff as well. It's not that the other insurance companies not doing it. I think it's just they're trying to figure it out. But I think a real big push for All Shores in regards to them having the wellness coordinator is awesome. Because then you can at least try and figure out, and they've got like the ones that are trying to do like a caseworker type system, and it's not necessarily going to be everyone needs it. So it'd be awesome if we could have a system that wasn't necessarily individualized to each insurance, but we had like a hub. I mean, talked about the charities, whether you have the caseworker or coordinator through the charity, and then the person can sign up. They get the education, they have the support from other people in the community. They can use the person as a peer support, and then they basically can have a caseworker through that.
That makes sense.
Yeah.
As we wrap up, I'd love to hear where you feel your practice individually is going, where your company that you work for is going, and obviously the charitable things you're working on.
Yeah. So still working on the research here. So there's a survey that's ongoing, hopefully till the end of the year. Trying to figure out how things have improved since we did the last survey. It's a little bit more detailed in regards to what we can do for rehabilitation, not just from the hospital, the whole continuum. So hopefully in regards to that, that'll be wrapped up, and then we can kind of start to make some improvements. Collaborating with some staff in the hospital and collaborating with some of the community partners to try and do more education events, support groups, things like that. In regards to, we talked a little bit off air, like volunteering, helping some stuff, helping with the Stroke Association. They're really pushing to try and do more support groups and try and push things that way. I think that would be an awesome way to kind of like give people the support. Obviously, it doesn't need to be just necessarily for stroke. There's so many conditions that we've talked about today, neurological conditions in general. If we could have that support for people that need the funding and help. Yeah, I think that there's exciting stuff on the horizon. I think there's lots of work that still needs to get done from my side, from the healthcare system in general. Still obviously doing the research stuff on the side. I think the goal would be to be able to like do something with that research, whether we could do like a national strategy or map the pathway of what we're doing, like kind of how Bermuda Cancer and Health did an amazing job with their pathway mapping and trying to get things in place. It would be awesome if we had some sort of system where we could do that for neurological conditions and stroke, right? We talk about stroke a lot because it's obviously part of my specialty, but
it's maybe the most debilitating
and also the
there.
incidences, but the incidences are rising, right? It's like 5 incidents a week that we're having here in Bermuda, like obviously different severity of stroke, but that's something that we need to address.
Maybe that and Alzheimer's are maybe like the two of the worst things you could be diagnosed with, you know.
So I think that that's one of those things is like, and obviously once you start putting a structure in place for using stroke, like you then can duplicate that for other things, right? And to be able to use that to kind of collaborate with other community partners. How do we change the system in regards to that? Obviously, we said there's no perfect healthcare system, but it would be awesome if we could kind of... Bermuda has the capability to be this world-class, world-renowned area for rehabilitation and like outcomes and like what we can deliver, because you can actually do the research on this like population that's very contained, right?
Captive audience.
Yeah, for sure. But also you can say like, okay, we know out of whatever, is it 63 or 66,000 we have of the population, this is what we're having for people that have had the instance of stroke. This is what we've done for rehab compared to the global standard. These are the outcomes that we've had. Like we have a real opportunity to be able to be like, this is what we're doing in delivering this world-class care.
Sure. Well, Dr. Watkins, thank you. This is awesome. We'll link all your stuff on the show notes about you, about the charities that you're helping with, and about your company. So thank you. It was an awesome chance to speak with you. Appreciate it.
Yeah, thank you so much for having me. I'd just like to point out, I'm sorry for my babbling. We did talk a little bit, but I was sidetracked. I thought we were talking about the podcast, but we went straight for the talking. So apologies for my less eloquent moments in there.
You did perfect. Awesome. Thank you very much.
Thanks so much for having me.
Thank you for joining the conversation on business and technology in Bermuda. If you found value in today's discussion, share it with your team. Keep building, keep leading, and we'll see you next time.